My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan. And today our Learn and Share topic is Aging Well with Epilepsy. And we're very fortunate to have Adriana Tanner, who's an epileptologist with St. Mary's Healthcare, with us today. And Dr. Tanner, can you please just introduce yourself and share a little bit about your clinical and research interests, and then also any experience that you have with this particular topic that we're discussing today?
Sure. First of all, can you hear me okay? I'm on the speaker, but I can switch to the headset.
No, you sound great. Yeah.
Okay, good. Well, so first, thank you so much for having me. I'm really pleased to be speaking today. And my name is Adriana Tanner. I'm currently the medical director of the Epilepsy Center at St. Mary's Healthcare. As you mentioned, Rose, I'm an adult epileptologist. I have been in Grand Rapids for about 6 years. Prior to my post here, I was at the Cleveland Clinic for about 3 years. My clinical interests are in the treatment of epilepsy, the treatment of intractable epilepsy. I am really interested in epilepsy surgery, as well as women's issues in epilepsy. And more recently, and I guess increasingly so, I have been interested in seizures in older adults, in part due to the fact that we have seen an enormous increase in incidence in seizures in this age group, I guess over the last decade. In terms of research, I'm interested in semiology. I'm interested in outcomes after epilepsy surgery. And again, most recently I've started doing some research into how the characteristics of different epilepsy syndromes in older adults, and especially in how we are evaluating these patients in epilepsy centers. And actually, I'm working with one of our nurses in looking at extratemporal epilepsies in older adults.
Oh, great. So I wanted to start out by just asking the participants in the call a question, or a couple of questions. So for those of you who are not yet seniors, I know there's some who are in their 40s and 50s and maybe even younger. What are some of your biggest concerns as you approach older adulthood with epilepsy? And then have any of you done anything to prepare? And then also for those of you who already are older adults, what have been some of the biggest challenges that you've faced relating to epilepsy and older adulthood, and then how have you coped with them? So if anyone wants to share some of your thoughts on that, that would be a great way to get us started today.
Well, this is Janet, and I'm 62,
mm-hmm.
and I've had epilepsy all my life, but was never diagnosed till I was 36. And my concern is, as I've gotten older, the seizures have changed, and they've gotten worse. I'm allergic to almost all the medications, but 2 right now. And the doctors, the neurologists always ask them this question: what's going to happen as I get older? And they go, oh, seizures usually get less. Well, in my case, it's doing the opposite.
Oh, no.
Okay. And so it's just like that's what scares me. This year I totaled our car, which I've never had an accident in the car before. And I blacked out with a seizure.
Ooh.
So now I can't ever drive again. But the thing is like, I want to know what I need to expect from this. Do people with epilepsy get dementia faster than the rest of the public because of it?
That's a really good question, Dr. Tanner. Can you address that, whether there's an increased risk for dementia or Alzheimer's disease in particular among people with epilepsy?
Yeah, the short answer is we don't know yet. We are seeing increasingly so that seizures are or could be part of the natural course of Alzheimer's disease in other types of dementias. So we know that in that direction there is a correlation. We don't know if the correlation works in the opposite way. In other words, if you will see more dementia in epilepsy patients We do know that epilepsy patients have some more difficulties with memory, et cetera, and I think we will address that later in the call. But I think we definitely need more research to answer that question.
Okay.
Anyone else? A couple other people were started talking.
This is Al.
Yeah, go ahead, Al.
I guess I'd like to talk a little more about that. We need a little more research, but what does that mean? Are we going to come up with that? Are we looking on it? Does that look like something in the near future, or is that going to be like 20 years from now, or what?
No, I think we're looking at shorter. I think there's really interesting research in looking at, again, some shared characteristics between, for instance, the anatomic changes that we see in Alzheimer's dementia and in epilepsy. And I think we're going to start sort of retracing steps and look at the genetics of both and some shared genetics. I think it's a field that is growing, and no, we're not looking at 20 years down the road. I think it's a much shorter result.
Because with seniors, I would feel that's a very, very important situation. If you've got epilepsy and normally you maybe wouldn't dementia till you're 70, but now you're going to get it when you're 60. So I
completely agree with you. I think it's an important question to answer, and like I said, I think we've established in a correlation in one direction. We're looking now at the other direction. So we know that patients with Alzheimer's and other types of dementia can have seizures, and they can be part of that disease. We're now looking at the opposite. Do patients with epilepsy are more prone to developing that? And I think it's too soon. I mean, I think the jury is still out on that.
What's the difference? Well, you can have Alzheimer's or dementia.
Well, Alzheimer's is the most common type of dementia. So Alzheimer's is a type of dementia and the most common one in our population.
Okay.
Okay. So did anyone else have any comments or concerns or challenges that they wanted to share? Otherwise, we'll start talking about the topic in a little more depth.
With me, I don't know if it's partly because I'm aging, I'm 56, and if it's partly that, and it could be because of the seizure thing, although I haven't had a seizure for a while, thank God. But I think it could possibly be that, and possibly because of the surgery I had some years ago. But it's frustrating and scary when I don't remember something, or worse, when it's a danger thing. Like a couple of times it happened to me. Thank God my friend was home with me, and I'm not sure what would have happened if she hadn't, if I'd have burned myself or what, but twice I didn't even realize I had turned on the stove. I looked and, the stove is on. And my friend said that she hadn't noticed me turning it on, nor could I remember doing it, and she hadn't done it. And something like that is scary, because what if sometime I do something that's really dangerous and I do cause a fire or injure someone? And the memory thing, it's scary.
And that's something certainly that we're going to talk about is, in terms of what's related to epilepsy, what's related to possible dementia, what's related to the normal aging process, and how do we distinguish that and cope with that. So, so if you're an adult with epilepsy, roughly speaking, what are the chances that you'll continue to have active epilepsy for the rest of your life? Is there a percentage that you can estimate?
Yeah, I think for a significant proportion of adults, epilepsy it's going to be a lifelong condition. There's several studies that have looked into that, and I'd like to mention a recent study that was published recently, was a study done in Glasgow where they follow, I believe it was over 1,000 patients for about 18 years. And the study confirmed some things that we already know, that a lot of patients did actually, fairly well and, were seizure-free and et cetera. That was about 70% of patients, but they were still taking antiepileptic medication. So for a lot of them, they remain on antiepileptics. I think it's important to look sort of a different group. I think sometimes it helps me understand it better. So, for instance, one large group is patients with what we call the idiopathic or primary generalized epilepsy. That's the type that oftentimes starts in childhood or adolescence, that we think has a genetic basis to it, and even though patients may not have relatives with epilepsy, we think it's sort of inherited as a trait. And those are the times that sometimes patients outgrow, right? But patients that outgrow that do so by the end of adolescence. So if patients have not outgrown it by then, chances are they have it, and they will have it for life. So that's a big group that again, if I meet a patient, they still have seizures, they're in their mid-20s, I tell them, you're probably going to need medications for the rest of your life. Patients that have more of the, what we call the symptomatic generalized epilepsy, for instance, the type that we believe is caused by diffuse damage to the brain, for instance, with cerebral palsy, like one of you mentioned, or diffuse damage to the brain, like something in utero or around the time of birth. Because there's damage to the brain, we anticipate that the vast majority of these patients will have lifelong epilepsy. And then the last group I'd like to mention are those patients that have focal or partial epilepsy. And again, remember, those are the patients whose seizures start in just one area of the brain and spread. And so most of these patients, again, will need antiepileptic medications for life. I guess the huge exception would be those patients that become candidates for epilepsy surgery and that undergo successful resections that eventually can, of course, become seizure-free and be medication-free. So to answer your question, yes, I think a not insignificant majority of patients with epilepsy will end up being epileptics for life.
How about a brain tumor?
That's a good question. Whenever, I guess in my mind, I think of anything that will injure the brain, right? Either if it is a tumor, scar tissue, a bleed, blow to the head. Whenever you have an injury that is there, that is hard to take away, then in my mind, the chances that you're going to become seizure-free and that seizures will go away are low. And again, I'm not saying, zero, and obviously I don't know, your particular case, but whenever there's something that has already injured the brain, I think that the chances that that will continue to cause seizures are very high.
What about infections in the brain?
Infections can behave in a similar sort of situation, and we do consider that having had infections of the brain is a risk factor for developing epilepsy. Of course, again, there's not a cookie cutter, but if someone has experienced a bad case of viral meningitis or viral encephalitis, where there's again damage to, for instance, the temporal lobe, which is a very common scenario, then these are patients that oftentimes have a hard time, being able to become seizure-free and stopping medications. I have also seen patients that have, done very well after infections and have recovered.
Let's start by talking about some of the key physical changes that are associated with aging that can have a potential impact on seizure control. And first, what are some of the potential effects of menopause? That's something that's associated with aging that can certainly have an effect on epilepsy and its management.
Yeah, thank you. I think that's a great question. So I like to look at it in both ways. One is what does epilepsy do to menopause, and then what does menopause do to epilepsy? So I think there's more than one lady in this phone call, so I think this is relevant for all of us. So let's start with the first. What is it that epilepsy can do to menopause? And so let us remember something. So menopause occurs usually at the average is about age 50 or 51, and we define menopause as the time when the women's ovaries stop working, and is usually defined by having gone 1 year without a period, without menses. we call perimenopause, and you might have heard that name, when women start having irregular menses with or without some of the other symptoms, right? I mean, everybody's heard about hot flashes and all that. So there is some evidence that menopause can occur a little earlier in women with epilepsy, and it appears that that's more the case for women that have an increase in seizures around period, something that we call catamenial epilepsy pattern, like a definite increase of seizures, immediately before menses, or only seizures around the menstrual period. So it appears that that some of these women may end up having menopause and perimenopause as early as like a decade earlier than other women, which is important, talking about fertility and things like that. But overall, I guess excluding these women, overall, most women with epilepsy end up entering menopause at about the same age as women in the general population. Now, the second and probably most important question is, what does menopause do to epilepsy? And what is important to remember is that ovaries produce two hormones, right? Two main hormones, and everybody's heard about the estrogen and the progesterone. And hormones can affect seizures, not by themselves, but by creating an environment whereby they can change seizures. And so, for instance, in a very plain matter, we know that estrogen may produce or increase seizures, and progesterone has the opposite effect. But that's a very simplistic way to put it. In any event, it appears that the vast majority of women, however, in general with epilepsy, have no change in seizures as they go through menopause. Smaller studies looking at different groups of women show that women that have catamenial epilepsy, that is the type where women have an increase in seizures around the menstrual period, end up having more seizures around the time of menopause, or also known as perimenopause. Okay, so that's sort of like the bad news. The good news is that then once the ovaries start producing the hormones, then these women end up having some type of improvement. Again, that only sort of applies to these women that have the catamenial period. Another study that I read recently showed that about a third of women that went through epilepsy stayed the same, so had the same seizures as before. About a third improved, and perhaps these were women that had some hormonal-related changes. And there was a third that actually got worse during and after menopause. Like I said earlier, a lot of these studies have involved really small number of women. These are studies that are hard to do because it would involve following women through decades before, during, and after menopause. And we definitely need larger studies to identify which women will improve and which will worsen. One question that I get asked often by my female patients is whether women with epilepsy will benefit from estrogen or hormone replacement therapy. And the answer is probably not. There's some studies that have suggested that can actually increase seizure frequency. So again, I guess to summarize, if you're a female and if you have a lot of seizures around menses, you might get worse during menopause. That's the bad news. The good news is you might get better after menopause. If you don't have that, there's about a 30% chance that you will improve. 30% you will stay the same. 30% it might actually worsen.
Okay. I'm 77 years old. I have a brain tumor, and I went to the doctor and I asked him, what is causing me more to lose my memory of those three subjects? And I was just wondering if the doctor would know what's causing my loss of memory more of those three subjects.
Well, let's talk about that. We'll skip ahead to that question. So memory problems, as we all know, are pretty common in epilepsy, and then you can also have memory problems associated with the normal aging process, and then you can also have dementia and Alzheimer's disease that can affect memory. So in older adults who are experiencing memory problems or possibly even decline in cognitive function or memory function, how do you distinguish between those different potential causes, or does it even matter? Do you even need to distinguish? And then also, what are some of the key things you can do to deal with those memory problems?
Great. Yeah, I think that's a valid question. Number one, is it worth trying to tell them apart? I think so, because I think you would potentially, as a physician, I think I would approach patients differently and look for different ways to treat them. When you are faced with a patient with mild memory deficits or very mild memory difficulties, it can be very hard to differentiate that from, like normal aging or very early stage dementia or the problems that we see in epilepsy. A lot of patients with epilepsy have some mild memory difficulties, mild to moderate, with memory and with attention. And I bring the issue to attention because what a lot of times patients perceive as memory difficulties is it has to do with attention, which then causes problem storaging and then retrieving memory. What causes these in epilepsy has to do with seizures themselves. And of course, what I told my patients is, look, if your brain is busy seizing or having lots of bad, electrical activity, your brain is not going to create good memories. But it also has to do with medication side effects, but also it appears with some long-term side effects with epilepsy. The main difference from the memory and cognitive difficulties that we see, for instance, with a patient with dementia. And when I use the word Alzheimer's, remember, and I mentioned this earlier, Alzheimer's is a type of dementia, and we talk a lot about it because it is the most common type of dementia in our population, okay? And so, remember, in Alzheimer's disease, you see a definite change and decline in memory, which, again, in the case of dementia, it's completely disruptive. But we also see a change and a decline in executive function. And let me explain what I mean by that. Patients have difficulties, for instance, planning or solving problems. They have trouble following something that is familiar to them, like a familiar recipe or keeping track of monthly, like bills, balancing checkbook, completing familiar tasks, at home or at work. They get confused with time or place. They have trouble understanding sort of visual images, like signs. They have new problems with words in speaking or writing, misplacing things, losing ability to, for instance, sort of retrace steps. But probably one of the most important things is that a patient with dementia, and again, especially with the Alzheimer's type, is that they will have really poor judgment. We will also see withdrawal from work or social activities. And so when I mention these things, a lot of patients will say, I had one of them, right? I mean, and a lot of us have misplaced keys. Believe me, I don't know how many times I go out in the parking lot and I have no idea where I parked my car, and I'm 43. Isolated, they kind of happen to all of us. But what it is consistent is the presence of all these symptoms in a progressive fashion that would make me think as a physician more about dementia and not about epilepsy. Now, what I tell patients is if we need to really tease them apart, then I think you need to be tested. And I think there's, neuropsych testing that would look into executive function. It would help us determine that. So if someone has a concern, what my advice is, bring that to the attention of your physician. Sometimes unless patients say something, we don't know. And if you have that concern, we can always do a little bit more testing.
Well, that's why I'm asking the question. Exactly why you just said that, because I have some of those symptoms.
Right, and having some of them in isolation doesn't mean that that you are demented. Like I said, all of us in isolation might have, misplaced things or, forgot an appointment. But like I said, when in a patient that has clear dementia, they all occur. They're kind of abrupt. They disrupt life, and they progress faster. So. I don't know you, but I would venture that you probably don't have dementia if you're in this telephone conference talking to me about this. And my guess is you have some mild memory difficulties or moderate difficulties due to epilepsy and your medications. But again,
I've been a problem solver all my life, and that's what I did for a living. And now I'm having problems doing that, and I do misplace things. I do have problems doing it, and now I'm having problems with solving problems. And so those things that you mentioned are exactly what I'm problems with.
Right.
So,
and I think to determine the extent to which those problems are affecting your life and what the possible causes are, that's where you really need to consider neuropsychological testing if you're concerned that maybe it's more than just epilepsy.
Discuss it with your physician, absolutely. Yep.
Right.
Okay. Let's also talk a little bit about bone loss. Aging itself can increase the risk of bone loss, as can certain anti-epileptic drugs. And then also aging, seizures, and side effects can increase the risk of falls. So as a result, you can see more broken bones in older adults with epilepsy. What are some steps that adults should take to minimize the risk of osteoporosis and fractures?
Rose, I think you've just raised a critical point, and I think as our population ages, and as we are seeing more and more older adults with epilepsy, this is something that is just going to hit us like a snowball. I think it is a huge problem, and I don't think we talk enough to patients about this. I think a key element here is that I think it is important to make sure patients discuss their medications individually with their doctors. Most of you know some anti-epileptic drugs can increase the risk of bone loss. And what I tell my patients is that alone is not a reason to switch, medications for any given patient. But I think it is an important factor to take into account when you think about switching meds in a patient that is aging, or to think about prescribing that medication in a patient that is elderly when the medication is needed. Now, there are a lot of other medications, not anti-epileptic drugs, that can also increase the risk of bone loss. And so, like, for instance, the steroids, right? So I think it is really important to make sure everyone involved in the care of a patient knows this information. Something that I think is critical is for patients to know, whether or not there are risks for osteoporosis. And we have known that risk factors for having osteoporosis, aside from taking certain anti-epileptic medications, is, for instance, female gender, being white or from Asian descent, having strong family history of osteoporosis, having a small frame, going through menopause if you're a lady, hyperthyroidism, sedentary lifestyle, smoking, drinking too much alcohol, and certain types of weight loss surgery. And so, of course, many of them we cannot change, right? I mean, gender, ethnic background, et cetera, of course we cannot change, but I think patients should be encouraged to change the ones that they can. And for instance, the single most important thing would be quitting tobacco, avoiding drinking alcohol, and promoting exercise. I think physicians and patients alike need to discuss this. I think preventing falls is important, and I recommend doing a kind of like a walk through, patient's house. Make sure you're wearing adequate shoes. Make sure, things as simple as, remove as many electrical cords or make them, really short is important. Remove area rugs. Make sure you don't have slippery surfaces in your house. Keeping rooms lit, like brightly lit, believe it or not, can go a long way. Installing grab bars. People don't think about it, but maybe patients have difficulties getting out of bed, getting out of the toilet, or getting out of the shower is important. The other thing I encourage is, get tested. The most common test to measure bone density is the dual energy X-ray absorptiometry. It's a super quick procedure, painless, and it gives us a really good measure of whether or not there's osteopenia or osteoporosis. Patients also should have vitamin D level checked. And most of us, epilepsy or not, are really deficient here in Michigan because we don't, we're not exposed enough to the sunlight. And then ask, do I need to take medications for osteoporosis, like bisphosphonates? But most importantly, I think patients always should take supplementations. I tell all my patients, take calcium and vitamin D, period. If you're a woman over 50, you should take 1,200 milligrams of calcium and 800
milligrams of calcium.
But I think overall, I think it is important to have that conversation with your physician. Is this the best medication for me? If I am at risk of developing osteoporosis, should it be changed to an agent that is not involved in producing that, and then preventing falls at home?
You said 1,200 milligrams of calcium, and what was that other?
Vitamin D, if you're not deficient, at least 800 international units. If you're deficient, we recommend about 2,000 per day. And I can tell you a lot of us, so first of all, the seizure medications that cause osteoporosis do so because they reduce vitamin D, right? They increase the metabolism of vitamin D, and vitamin D is the one that takes calcium from your, what you consume in your food and sort of brings that across your intestine into your body. So if you don't have that, your body starts taking calcium from your bones, and that's what happens. And so your body makes vitamin D by when you expose your skin to the sun, your skin switches some compounds into vitamin D. And of course, we don't get that enough sunlight here in Michigan at this latitude. So everybody should be checked. I have to share, I checked myself a couple of years ago. I was shocked. I was very deficient. So now I take it, every day religiously.
It seems like that should be something that should be part of standard primary care, but it's not.
Absolutely, I agree with you.
Yeah.
Speak up. Ask your doctor, hey, should I be checked for vitamin D level? Yes.
Good to know.
Dr. Tanner?
Yes, ma'am.
Just a quick question. I understood that if you don't take calcium along with your vitamin D, then the vitamin D is not easily absorbed.
The opposite. If you take calcium alone and you're deficient in vitamin D, most of the calcium will kind of go through your system. You always want the vitamin D together with the calcium so that the calcium is absorbed.
You can get this type of tablet that it actually goes, it's both is in it. Both are in it. Calcium and vitamin D are in it. In fact, that's what I take every day, twice a day.
Yeah, exactly. Like there's commercial preparations like Caltrate. Then a lot of the big pharmacy chains have like their own pharmacy, like store names. Like I buy my at Costco, and so I don't buy the most expensive one. But some people like to take it separately, and they take calcium alone and then the vitamin D separate. I don't care. Just take them both.
Okay.
Great. So as you get older, another issue is that you tend to metabolize medications more slowly, which increases the risk for drug toxicity. What are some of the signs of toxicity, and then what can patients and family members do to reduce the risk of toxicity?
Good, yeah. The signs of toxicity can, of course, vary slightly from medication to medication, but overall, I would say that many medications would produce things such as increased somnolence, and, drowsiness, nausea, vomiting, dizziness, double vision, clumsiness, difficulties with balance, slurred speech, and whatnot. I think things that are important to discuss with your physicians are to check plasma concentration, so like checking levels, and I tend, in younger adults, not to check plasma concentrations a lot, but I see in older adults it's actually very important, and I tend to follow them more closely in my older patients because, again, your liver metabolism slows down. We know that the kidney metabolism changes, and so you might really not require doses that you would use in younger adults. So I think checking levels more frequently is important. I think if you notice any changes that you think might be related to medication, call your doctor because things can change and can change fast. I mean, it doesn't have to be necessarily, a long change. And then checking for function as part of your primary care visits, checking for liver function tests and kidney, and monitoring that it is also important as well, so that then adjustments can be made to the medications.
What else did you say should be checked? I know you said function, but what did you say before that?
Oh, I said, so checking levels of medications. And then, at least for my patients, routinely, at least once a year, I like to check liver function tests. And then, once a year, what we call a comprehensive metabolic panel, kidney function, etc.
And when I talked to my doctor about that, you said comprehensive what?
Metabolic panel, just to check how your kidneys are working. It looks at things like protein, how much protein are you making? I mean, do you have normal protein levels in your blood, etc. And again, in normal adults, in younger adults, we don't worry too much about this because there's not too many variations in these parameters that would alter medication levels. But I think in older adults, they do fluctuate enough that we need to worry about them and worry about levels. So again, I tend to monitor more levels in older adults than in younger adults.
Okay. Another issue that comes up with aging is that seizures can easily be confused with other symptoms and other conditions that are associated with aging, like Parkinson's disease, tremor, sleep disorders, dementia. We already talked about stroke. And mini strokes or TIAs, and then even hearing loss. Someone not responding could be a sign of a seizure, or it could be a sign of hearing loss. So what are some of the key features of seizures that help to distinguish them from some of these other conditions, and particularly stroke, since the consequences of not recognizing a stroke or thinking that those symptoms are a seizure and not a stroke can be pretty serious?
Yeah, that's a very important question. I think we need to look at two separate groups. I think one group is a patient that has had seizures all his life or her life, and continues to have seizures through as they become older. And another different one is new onset seizures in the elderly. I think recognizing seizures in the first group, in the first category, is a bit easier. Family members and even the patient can recognize, when they have seizures or if they have just had seizures. So I think for them it's a bit, easier to recognize. Telling families that what are the usual symptoms of the seizures, what the patient usually does, the usual length of the seizure, the usual characteristics of what the patient does after the seizure is important. I always worry a little bit more about seizures that tend to start late in life, because then that's when it becomes really, really hard. And that's a challenge for all of us in our field because, first of all, accurate patient histories can be really difficult to obtain because of, like you said, language disturbance, hearing loss, implementation. But again, in my mind, important points to remember are the following. The most seizures in older adults are usually focal, right? So the most common type of seizures that we'll see are complex partial seizures, which, as you know, can come in sort of many shapes and form. But and we know that in elder patients, they may have some atypical seizures. I would say that it is important to recognize that those seizures, the average length is about a minute or two. So I think duration is an important key element. Number two, what comes after the seizure, the aftermath, also known as the post-ictal, tends to be rather prolonged in older patients. But that sometimes can be acute, like an odd episode followed by really prolonged confusion. That might point towards a seizure. In comparison to other events, then, for instance, syncope tends to be a bit shorter, and then TIA or transient global amnesia tend to be a bit more prolonged. Older patients with epilepsy, the type that starts usually late in life, usually don't have temporal lobes. The seizures are usually what we call neocortical. They're usually frontal or parietal, and they tend to have some more focal signs and symptoms, so like motor manifestations in one arm or one hand, or loss of sensory and whatnot. And Ross, I agree with you. I think they can be very tricky to tell from stroke. if it's something that starts new and there is a concern, I think it's always prudent to come to the emergency room or see your physician. But if it's something that has been repetitive, I think it would point more towards a seizure. But I think obtaining an accurate history, going over the history of seizures with patients, prior, timing them, looking at how patient responds after an episode, they're all key elements to tell them apart.
What about auras?
Auras are probably the best signs to identify seizures. In patients that have had seizures all their lives, that have consistent auras that appear before seizures, are perhaps the best localizing sign and perhaps the best way we have to tell them apart from other episodic neurological difficulties. The issue is that not a lot of older patients have auras. And I'm not talking about a patient that has had temporal lobe epilepsy since the age of 30. I'm talking about the 71-year-old patient that has never had seizures and all of a sudden starts having them. Those patients tend not to have auras. Why? Because what causes seizures in older adults, again, new onset seizures, right, are things like stroke, dementia, things that affect the elderly. And they tend to affect areas of the brain where auras are not as common. So that's a very good question. If you see an aura, I would say that's probably a seizure, but precisely a lot of older adults then don't have auras, which kind of complicates things a little bit.
I can depend. I can tell you what time it is, at what time I get an aura, because I don't have to look at a clock. Every night I get an aura at between 5:30 and 6 o'clock.
Right, right.
I know what time it is. And I haven't. Now, I've never passed out for an aura. But, it happens. When I passed out, I never had an aura. When I passed out, bang, I just fell on the floor. I never had any warning. So, I've never had, it's completely opposite.
Right. Well, no, I don't think your case is that rare. I mean, not. That's what I said, that having a consistent aura, and in your case is not, right? Because evidently you've had episodes that are not preceded by an aura. But if someone has consistent aura, meaning, 100% of the time prior to every seizure, then I think it's a really reliable sign.
Yes, it is.
Correct.
But when I have a seizure, I don't have any warning. I'm just walking along, and bang, I just fall. I pass out.
Well, that must be scary.
I've done it 2 times. Both times I've broken a collarbone.
Oh, no.
Oh, yeah. So sorry to hear that. Unfortunately, I don't think you're alone. Yeah. I think that happens more frequently than we think.
Well, thanks.
Let's talk a little bit about depression, which is associated both with epilepsy and aging. So how is depression different in older adults, and what, if anything, is different about its treatment?
Good. Depression, let me start by saying that depression, anxiety, and most mood disorders are more frequent in patients with epilepsy than in the general population across all ages. Again, one of those things that I'm afraid we're not talking enough with colleagues and with patients. So turns out that this increase has nothing to do with seizure control. In other words, what most people will think is if you have poorly controlled epilepsy, you're depressed because your seizures are poorly controlled, but it turns out that that's not the case, that even patients that are very well controlled and are seizure-free have depression. And so anywhere between 20 and 50% of patients above the general population will have depression, anxiety, or mood disorders compared to the general population. So we know that depression is common in patients with epilepsy. We also know that these mood disorders and psychiatric disorders are increased with age. And what is really problematic is that if you take an older adult and mix together depression and epilepsy, what you get is a rather poor quality of life. And as many of you know, we have ways to measure quality of life indexes, and not surprisingly, right? It decreases the quality of life and the function of life in persons with epilepsy. I think that the impact that depression can have in an older adult with epilepsy is huge. And the impact is on the quality of life and socioeconomic indices and in many aspects of life. And it's just not adding one disease versus the other one. Is really much more than either illness alone. So I think the key point is that the presence of depression in elderly patients is strongly correlated with really poor outcomes. I am a huge believer that depression should be treated and should be treated aggressively, especially if you're an older adult. I think treatment should be sort of a multidisciplinary. I think patients should have counseling. There should be a talk about the use of medication management, and that, of course, has to take into account the patient's past medical history and past medication history. But I think the key point is a bad combination. And for those of you, patients out there in the call today, if you have a concern about that, I would encourage you to bring it to your physician. Sometimes patients won't tell us that. Sometimes it's maybe just a phone call from a family member who say, listen, I know you just saw so-and-so a couple of weeks ago, but, he's horribly depressed, he's not sleeping, he's not enjoying the things he was enjoying before, etc. That always worries me. It needs to be brought up to the physician's attention, and it needs to be treated.
Okay.
And I think there's a generational thing as well, too. I think older generations tend to look at mental illness or depression as something you just have to tough it out and not deal with it, or deal with it rather than seek help and see it.
Absolutely. And I think older generations look down on having to go see a psychiatrist is somewhat shameful. And I think mental illness has a really bad stigma, and I want to invite all the audience today to think about the issue of the stigma, because for years and still today, patients with epilepsy deal with some stigma. So we should know about it, and we should know that it has nothing to do with who we are and how each individual patient has an incredible life story to tell. And that there's nothing shameful to have to deal with that. Something that I tell my patients is that what science is telling us is that some of the same mechanisms in the brain that produce seizures produce a depression.
Wow.
And for some of my patients, that's liberating, because it's like, oh, so it's not me. It's my brain. And I'm like, yeah, it's some of the same molecules and I'm obviously putting it in a very simplistic way, but some of the same mechanisms that have to do with neurotransmitters are involved in those, and there's fascinating research into that. And for some of my patients, that gives them sort of permission to say, fine, I should take medication for it. And, you wouldn't walk around with a broken, clavicle like you after your fall, or, a broken arm. Why would you walk around with something so bad and difficult for your life as depression or anxiety or a mood disorder? They need to be treated.
Well, I hate the comment, you can't do what you did 5 years ago. I hate that comment. I can't do it. I don't care. I'll do it anyway. I'll do it. I'm trying to do it. And, okay, I got a collarbone. I wear a sling. And I'm still going to do it. I mean, I can't golf, but I'm still going to wear the sling, and I still go out and try to do some things. But you can't do the things you did 5 years ago. No, but I'm still going to do some things. And it does depress me that I can't do some things. But you're right, it depresses you, and I do get depressed because I can't do the thing. But if I didn't have the sling, if I didn't have broken my collarbone, then I could do those things that I did 5 years ago. So it does depress me because I broke my collarbone, and I broke my collarbone because I had epilepsy, and that was the reason.
Right. That can be depressing, It is with me sometimes that you can't. I don't mean anyone personally. I just mean people in general. Or me anyway, sometimes things I can't do that I used to be able to do. It sort of depresses me, or I think, gosh, I wish I could, like running. Nope, I can't really run anymore. I can't ride a bike because of not having good balance. or cook something unless somebody's home with me, because what if there was some sort of accident, fire, or whatever? That sometimes depresses me. I think, gosh, I wish I still could, but then, well, there's still a lot of things that I can do, so could be worse, could be better.
Right.
Absolutely, and I think part of it is sort of recognizing one's limitations. And I know it's easy for me to say, but I think once you recognize that, then again, that can also be very liberating. Oh, this is what I can do, and this is what I cannot do, and this is what I'm going to work on for the future. But that could be important.
So you talked about some mechanisms that are common between depression and epilepsy. One of those possible mechanisms is the loss of neurons in the hippocampus, or maybe the failure to generate new ones. And that's possibly associated with epilepsy, depression, and cognitive decline. And there was actually a recent study that showed that aerobic exercise in older adults led to increases in hippocampal volume. So the hippocampus was actually generating new neurons. Is there enough evidence yet to recommend exercise as a way to promote this hippocampal neurogenesis and possibly reduce seizures, depression, and cognitive decline?
That's a fascinating topic. I think there's enormous evidence to support the benefits of exercise sort of altogether, right? I mean, I'm a huge proponent of exercising, and we know that exercise is good to control weight, to combat health conditions, to improve mood, to boost energy, promote better sleep, better sexual health. And it's fun. From purely a neurologic point of view, like you said, there's research indicating that exercise may encourage brains to really work at optimum capacity, to cause nerve cells like this to multiply and strengthen their interconnections. And it appears that they can result in new treatments for Alzheimer's, Parkinson's, or spinal cord injuries. I actually have read some studies that have suggested that exercise might be an integral part of the treatment of depression. And I actually saw a study where they gave patients with mild to moderate depression either an antidepressant, and the other ones they gave 30 minutes of exercise, I think 4 or 5 times a week, and same proportion of patients in each arm of the study got better, meaning exercise was as effective as an antidepressant. And then, again, I'm not saying that you should not take antidepressants and exercise. Please don't take that. But I think that while we do not have solid scientific evidence yet to say, for instance, that it will reduce seizures, I think we have great evidence to support that exercise is important if you have a chronic illness that affects the central nervous system. And patients should be encouraged to exercise within their means. Because, of course, I'm not going to, depending on your capacity, you may or may not be able to walk for 30 minutes or to run in a treadmill or to do weight-bearing exercises, but within the capacity, exercise should be encouraged.
Right, and there is...
Could I go back to memory?
Go ahead.
I just have a question in terms of processing information.
Go ahead.
Okay, go ahead.
If there are... could it be that if there's too much information coming in, the brain just kind of shuts down because there's too much coming in, and neurotransmitters or whatever can't handle it?
Yeah, that's usually a process done by the frontal lobe, and I think in a lot of patients with epilepsy can be a factor of the medications that they're taking. Also has to do with lesions, and I'm not talking in your specific case, but lesions in the frontal lobe, where there are difficulties with what we call processing speed. And it has to do exactly with that, with the ability to sort through things fast, to slice them and organize them in your brain at the same speed. Some people are inherently a little bit slower to multitask. Again, some of it might not be due to processing, but to attention. I'm actually one of them. I have a hard time multitasking sometimes. But I think, again, if it's a concern, you might want to, neuropsych testing would answer that question easily because they have numerous validated tests to look at processing speed.
Okay.
There's a good question I asked before about solving problems. Is that one question? Maybe that's why I can't solve the problems anymore?
That has to do with it. Yeah, absolutely.
Okay.
Dr. Tanner, about how much time do you have left?
I think I'm okay till about 1:15.
Okay. Let's maybe we can just zip through some of these questions. So, sleeping. Older adults have a harder time sleeping, and obviously epilepsy can interfere with sleep as well, which can then lead to increased seizures and reduced cognitive function. So obviously sleep is an important consideration. Are there any particular recommendations for older adults in terms of getting better sleep?
Yes, my answer to the sleep question is going to sound very similar to my answer to depression. Sleep disorders are common in older adults. The most common one is not sleeping well and feeling like you're not refreshed in the morning, like your sleep quality is not as good. But there is an increase in the incidence of sleep difficulties as patients grow older. And as you mentioned earlier, Roz, of course, having a poor sleep could then increase the number of seizures. There's ample evidence in the literature that improving the quality of sleep improves seizure, and something to bring to your physician's attention. So my recommendations are, number one, good sleep hygiene, and you can look it up online, and you can Google sleep center or sleep sleep health, but basically it has to do with keeping a good schedule to go to bed, not drinking caffeine in excess, not exercising right before going to bed, not watching TV in bed, and things like that. The other thing is if there's questions about the quality of your sleep, or if there's any evidence that the patient might be snoring or stopping, breathing or snorting during sleep, then I am a huge proponent of having sleep studies done because, again, if you have anything like sleep apnea and we can fix that, it will improve the seizure control, you would decrease the chances that you have a stroke or high blood pressure, and you would improve your quality of life. So really important as we age that we take care of our sleep.
In terms of long-term effects of anti-seizure medications, we talked about potential bone loss. I've also read some about possible increase in vascular or the risk of vascular disease, but I've heard conflicting opinions from neurologists as to the extent of that. What's your opinion in terms of people, particularly in older adults who've maybe been on anti-epileptic medications for their whole lives? Should they be concerned about possible increased risk of vascular disease because of the effects of the anti-epileptic medication?
Yeah, I actually looked into that myself, and I think this is something that we need to really look in more detail. Some of them, and I think they're the same ones that produce bone loss, that are the enzyme-inducing, can alter the metabolism of something called homocysteine, and therefore increase the risk of vascular disease, stroke, and whatnot. I don't know that we're at a point that we treat this as a risk factor for stroke and that we need to treat these patients like we treat other stroke patients, like with aspirin and things like that. But I think if you are a patient that have tons of other risk factors for stroke, I think we need to stop and be careful about it. I tend to stay away from the older antiepileptics, and I think if you're older, if I'm meeting a patient that is elderly for the first time and this patient needs an antiepileptic, I'll try to stay away from those, and I will lean more towards the newer antiepileptic medications. If you're a patient that has been on an antiepileptic, let's say Dilantin for 40 years, I don't think it's an automatic switch to something new, but I think it's worth looking into the long-term side effects of it and see, what are the risks and benefits of switching you to a newer antiepileptic medication. And I guess that's the message. It's at an individual case-by-case scenario, but I think worth discussing.
Okay. And then lastly, epilepsy surgery. Is it still a possibility for older adults?
Yeah, absolutely. There's not a whole lot of research out there. As you know, we could never do trials like do sham surgery in some patients and do the real one in others. Of course, we can do that. So all we have is retrospective data. But what that retrospective data show is that epilepsy surgery is overall as effective in older adults as it is in younger adults. The differences are that we have a little bit of a higher incidence of complications, which is expected, right? I mean, if you're older, you might have a little bit more complications. And that sometimes we get a little bit more concerned in older adults about memory difficulties after surgery. But I think it is a possibility. I think if a patient thinks he or she might be eligible or might be a candidate for epilepsy surgery, I think it is worth studying. Our oldest patient that we've operated here at St. Mary's was 67. She had surgery last year. She's been seizure-free for 1 year, and she's doing wonderful.
Great.
And she recovered, beautifully. She actually just came back with driving form. She wants to go back and drive. So I think the answer is yes, of course.
Okay, great.
We
have about 3 minutes left for questions for Dr. Tanner, and I wanted to make sure that anyone who hasn't already asked a question gets a chance. Is there anyone who hasn't already asked a question who has a last question for Dr. Tanner?
Yes, I do.
Yeah.
I got 2 questions. Is caffeine really bad for someone that has epilepsy?
And then your second question?
Oh, I thought you were going to say 2 questions. Okay. Overall, no, but moderation is the key element here.
Okay.
Is it bad that you sip coffee, like a whole pot or a pot and a half all day long? That's bad. That is really bad, but it's bad for every human being. I don't think that would be good for anyone. I think coffee in moderation, a cup or 2 per day, should not be a bad thing for a patient with epilepsy.
Okay. And my second question, I had surgery, and they said that the time limit, recovery time, would be for 2 years. What is your recovery time?
Well, I don't know what you mean by recovery. You mean just recovering from surgery or time to get off medications, or I'm not sure I understand the question.
Well, they said, give it 2 years to see if it'll do you any good.
Yeah, I mean, I think it comes from studies that basically I think is a little bit of an arbitrary number, but it's a number that we like because if you have epilepsy surgery and you're seizure-free 2 years after it, the chances that you stay seizure-free are really high, and they're above 90%, about 92%. So many of us in the field tell patients to wait at least 2 years before we can remove medications, simply because I think we will feel better about it, okay? Some of us are moving to waiting even longer. I have some patients that I've said, I think we should wait at least 3 years before we remove medications. But it's not really quite recovery time. It has to do with statistical chances that you will have seizures or not. Remember that if you remove medications too soon after surgery, there is a slight chance that you might have recurrence of seizures. So that's why we want to be cautious and wait for at least 2 years.
Okay.
And then the person should ask the doctor, because with me, I had surgery. There was a tumor, and first I was told it was cancer. Man, was I scared. But then it turned out to be just a regular tumor. But I had a tumor on both sides of the brain. One was removed, and the other, the doctor said, was too deep inside so that they could not safely remove it. So, I'm still on medications, but it really helps, and I am just so glad it did. That's something, a person might want to talk over with their doctor, and surgery really, truly can help, and medicine. So that's why I'm still on medication.
Dr. Tanner,
yes,
what do you think about vagus nerve stimulators?
In older patients or in general?
In general.
Yeah, I'm okay with vagal nerve stimulator. I think as long as patients know what they're getting. I like it. And that is that if you have intractable epilepsy, the chances that you become seizure-free with a VNS is about 2 to 5%. So you understand what that means, that 2 to 5 out of 100 patients that get implanted will become seizure-free, and that about 40 to 50 patients will experience about a 40 to 50% decrease in seizures, which is, some will say, similar to adding a new medication. So I think it has some advantages. It doesn't have some of the nasty side effects that some medications have, and if patients respond well, you may end up, decreasing medications in the future. These advantages there are, issues related to having good quality MRIs. Once implanted, it's hard to remove the wire. So I think it's one of the many things we have in our sort of armamentarium to fight epilepsy, and I think it needs to be used judiciously for very specific patients. I don't think everyone is a candidate for it. I hope that answers your question.
Yeah. Okay. I guess I'll just ask my doctor because he suggested I might try it.
Right. And I think, and I have a large population of patients with VNS. I think what I'm trying to tell you is that it's not a, like so many things, right? Not a cookie cutter thing where everyone should get one. I think it's very specific for certain patients. And I think as long as you know what you're getting, that's what matters. That you don't have unrealistic expectations.
Right.
Okay, well, thank you so much, Dr. Tanner. I want to let you go, but that was very informative for me and I'm sure for everyone else.
Yeah, thank you all for coming. Thanks for having me. Thank you so much. Okay, bye-bye.
Thank you.